Good evening, everybody. Thanks for joining in. We're going to start in a while. I'm just waiting for other people also to join in. We have more than 20 participants now, and I'll give another 3 minutes, and then we'll be able to start the next session. Thank you so much for waiting. Good evening, everybody, and welcome back. We are on to the third of the program today in the series of psychopharmacology. Today we have Dr. Mohan Sunil Kumar is going to talk on a different tale. Today he's going to talk on the ups and downs and how actually the mood stabilizer can actually make an impact and all the related tale of how mood stabilizers can actually offer a change and stabilize the mood. Dr. Mohan has his own innovative ways of explaining, and not everything is typed and printed. He'll have a lot of slides and a lot of explanation awaiting us. Over to Dr. Mohan Sunil Kumar.
Thank you, Dr. Mahesh. And I understand we are starting a new year. All of us are looking forward to 2021, and we are hoping all of us have a much more healthier, wealthier, active, peaceful kind of future. We are hoping the vaccines come in the forefront and help a lot more people. We are hoping community resistance improves and health overall improves. With the best wishes to all, let's start today's discussion. We're going to talk about mood stabilizers, where people are put on mood stabilizers and the need for mood stabilizers and what kind of challenges can come in when we think of using mood stabilizers. So I'll try to kind of keep it simple and clear for us to understand a lot of practical challenges as a clinician we might go through. The moment we talk about stabilizer, the first thing which comes to our mind is an image of a voltage stabilizer, right? Which we used to use for the fridges or the television. So a voltage stabilizer basically tries to safeguard the equipment we have by kind of preventing extreme fluctuations of voltages. Thereby, the fuse doesn't go off and we don't lose the machine, which costs us about 15,000-20,000 rupees, by investing on the stabilizer, which costs about 1,500 to 2,000 rupees. So that's a stabilizer. So my question is, what do you think is mood stabilizer? Is a mood stabilizer called mood stabilizer because of its antidepressant action, or do you call mood stabilizer a mood stabilizer because of its anti-manic action, or because of its antipsychotic action, or an anti-epileptic effect? Why do you call a mood stabilizer a mood stabilizer is the question. There are 4 choices. I want you to choose one among that as participants. Sriram, could you put up 4 choices poll? So why do you call it as a mood stabilizer? Is it because of antipsychotic effect, antidepressant effect, manic effect, or why do you call it as a mood stabilizer is the question. As I see the answers getting to come in, most of them seem to choose. That is almost like 50 to 60% of them say it's an anti-manic effect, which is the one which is the main thing. And about 27% believe it's also because of the antipsychotic effect, which makes you call it as a mood stabilizer. So what do you think is the answer here? The answer for that is basically, it's important for us to know, when you call mood stabilizer, a clinician or a psychiatrist is assuming some particular action, right? So what are we looking at when we are talking about mood stabilizers? One thing we know is there are a lot of mood stabilizers which are there are anti-epileptic drugs. Like valproate, carbamazepine, and lamotrigine are some of the most important mood stabilizers we have, and these are all well known for its anti-epileptic action. Now, one of the challenges you will see in your patients is you would prescribe a mood stabilizer in a patient and send them back home. They are very frenetically fixing up another appointment and coming and telling, why have you prescribed epilepsy drugs? I don't have epilepsy. So when they do a Google search with any of these chemicals, the first result would be talking about mostly about epilepsy and its action and those. So most of the times our patients would believe that they don't need this medication. So you need to understand a lot of mood stabilizers, or majority of the mood stabilizers, are anti-epileptic drugs we have. Does it mean we call mood stabilizers because of its anti-epileptic effect? Not necessarily, right? The gold standard mood stabilizer or thymoleptic, the gold standard mood stabilizer or thymoleptic is lithium. And in fact, lithium has nothing to do with anti-epilepsy kind of an effect. In fact, lithium at higher doses can end up causing seizures. It can cause myoclonic jerks. So you need to understand mood stabilizers, even though most of the important mood stabilizers are anti-epileptic drugs, you need to understand the gold standard one is lithium, which has no anti-epileptic effect. In fact, it has mood stabilizing effect. So why am I stressing this point is because when you prescribe this medication, a lot of times we have patients coming up and telling, I don't have epilepsy, why are you giving these medications? So it's good to kind of explain them why they need a particular medication and making them understand the need of the medication. So uh, it's very clear that it is the anti-manic effect which is more important when you're talking about mood stabilizer. So it is not anti-epileptic effect. When you're talking about a mood stabilizer, you're talking about anti-manic action. Why am I stressing this point here? If it is having antidepressant effect, they all come under the class of antidepressants. If it is having antipsychotic effect, they all come under the class of antipsychotics. If it is anti-anxiety medication, they come under anxiolytics, sedatives, like that. There are different medications, right? So mood stabilizers specifically will have some amount of effect, at least in anti-manic action. Now, is it true is the question. Is it true? Think about it. When I put it across, I wanted to get into the trap for you to understand. So mood stabilizer is not just necessary for anti-manic action. For example, lamotrigine is a very well-known mood stabilizer we use, right? Lamotrigine is a very well-known mood stabilizer we use, but does it have anti-manic effect? In fact, not much of evidence to say it has anti-manic effect. So what is mood stabilizer? It is not necessarily antidepressant. It is not necessarily antipsychotic. It is not necessarily anti-epileptic. It is not necessarily anti-manic. So basically speaking, you need to understand mood stabilizer still remains a vague term, and a lot of clinicians use it differently. But most of the times you need to understand when you're talking about a mood stabilizer, you're talking basically about an anti-epileptic drug, and specifically a drug which has a little bit of anti-manic action. You need to understand lithium is not anti-epileptic drug, but a mood stabilizer. Lamotrigine does not have anti-manic effect, but still comes under the class of mood stabilizer. So basically, you understand this class of drugs are kind of bunch of confusion, by the way. So next important thing is, what do you think is the answer? A patient with bipolar disorder is mostly spending time in which of these phases? All the phases are equally spent, or is the patient spending most of the time in mania? Is the patient spending most of the time in hypomania? Is this patient spending most of the time in depression? Now, why am I asking about bipolar disorder here? Basically, because when you're talking about mania, we are literally talking about bipolar disorder, right? So, my initial question is, as a budding psychiatrist or a clinician, what we need to know is, if at all we diagnose a person with bipolar disorder, what is the maximum duration spent in which phase? Depression, hypomania, mania, or all of these phases will be in equal. Shriram, please put up the 4 choices for people to answer. Let's see what people come up with. Are all phases equal? Is it manic phase? Is it hypomanic phase? Is it depression? So I can see that a lot of people, about 60 odd percentage of people, are choosing it to be choice 4, that is depression, and 30% of them have chosen hypomania as the phase in which they spend a lot of time. So what do you think is the reality? What do you think is the answer for this? We will be talking about it, and I have reasons why I'm highlighting this point, because as a clinician, we will deal with these challenges a lot. When we are talking about bipolar disorder, a common sense approach will say bipolar means there will be 2 poles, and basically the person will be swinging from one state to the other state. That's something all of us think of, right? Another thing, who know psychiatry well, like Kraepelin, when he spoke about manic depressive psychosis, or he spoke about dementia precox, which is schizophrenia, he basically said manic depressive psychosis is good prognosis, whereas dementia precox or schizophrenia is bad prognosis. And the way he decided the prognosis was basically based on the fact that uh, a patient with bipolar disorder or manic depressive psychosis would actually get better in between, and it would be episodic, and these episodes would be very discrete in nature. This is what is thought of bipolar disorder by all of us when we say bipolar disorder is basically mood fluctuations and it is episodic in nature. In real practice, is it true? Is it as simple as how we see? Is the question. Do we just see mood changes? Actually, we see different shades of gray, right? We see different shades of gray. We see people coming in and presenting in varied levels of mood intensity problems. Patients can come with manic phase, hypomanic phase, mild depression symptoms, moderate depression symptoms, severe depression symptoms. To add on to the whole bundle, you can have psychotic presentation, which can happen with mania. You can also have psychotic presentations, which can happen moderate to severe depression symptoms related to psychotic symptoms. So patients can have these mood states. Along with it, they can also have psychotic symptoms. Is it as simple as that? Clinically, we know it doesn't end there. We can end up seeing mixed states where patients can have both manic or hypomanic phase as well as depressive phase together. So in routine practice, we don't see bipolar patients as pure depression, pure mania, or just very clearly with one specific mood symptom. Sometimes they can have different symptoms and complex presentations, which can make it quite challenging and difficult to treat. Now, why is this important for us to know? The reason it is important for us to know is because this is what makes the prescription of a mood stabilizer challenging and difficult. Now, we expect patients with bipolar disorder to have such clear episodes. In our residency, right, when we are learning our psychiatry, we do mood chart and we draw a line and we put these episodes and we have a straight line in between. Is it actually so simple in real practice? Have you, when you see in day-to-day practice, do you see such clear episodes? Actually not, right? The course worsens many times. The intensity of the problems worsen, and the frequencies and the duration between these episodes kind of start shrinking many times. As the patient progresses with the illness, we see continuous episodes rather than actually kind of having very clear-cut episodes. Is it so simple? Not necessarily. The complication adds on. Subsyndromal symptoms come in. Patients don't have full-fledged clinical symptoms, but they don't have normalcy. They have subsyndromal symptoms. Some anger, some irritability, some suicidal behavior, some sleep problems. Like that, they come with a bunch of various problems, and it makes it difficult for us to diagnose and treat. So that makes it difficult. So bipolar disorder is not very simple condition. It can have its own colors and variations. Does it make it easy? No. Added on to it in routine clinical practice, we know a lot of this population are going to be using substances, and their mood will change under the influence of substances, which can actually make it even more complicated. Mental health problems of other nature, anxiety problems, OCD problems, self-harm behaviors, they're all going to be much more commoner in this population. So the baseline is never going to be straight, and that makes our clinical presentations quite complicated. Does it end there? Suicidal behaviors are an extreme important issue. In fact, a lot of time when you're treating bipolar patients, we are going to deal with multiple crises in their lifetimes. And what is the crisis we are dealing with? We're dealing with suicidal behaviors or self-harm behaviors, which are happening as part of the whole syndrome. So that makes it very complicated. Does it end there? No. Medical comorbidities add to the whole kitty. Obesity, diabetes, hypertension, all the lifestyle conditions, dyslipidemias, they all become more common in this population, which makes it even more challenging. Sometimes the drugs can influence it. Sometimes the sedentary life can influence it. Sometimes the biological vulnerability. People with bipolar disorder are vulnerable to many of these metabolic conditions. Understood? So basically, we even though expect bipolar disorder to be a clear-cut straight line with clear-cut episodes of problems, it's kind of quite messed up. It doesn't end there. Not necessarily, right? A lot of life stressors and challenges gets added up, and interpersonal issues, family issues. They would have got married, they would have breakups, they would have issues with their kids, they would have property issues, job losses. Such kind of stressors keeps happening. So as a clinician, it is not as easy as, okay, here is a patient with bipolar disorder, let me put him on mood stabilizer, chapter is closed. In fact, chapter begins after that. In fact, a lot of challenges come after that, and we need to deal with these people quite kind of in a very sensitive manner. We need to understand what they're going through. Things change dynamically. Today, what medication is helping them, tomorrow the same medication might not help. We need to increase the dosage, decrease the dosage, kind of understand what's actually happening. So why am I stressing this point is because we don't see what is described in textbooks in clinical practice. We see people much more complex. This picture is very gaudy, right? It looks a lot of colors. You just don't understand. That's how your clinical practice would be when you're dealing with bipolar disorder patients. I'm not talking about bipolar clinics where they're only seeing resistant cases. In routine practice also, you will see this. So as and more you clinically tune yourself, you pick up these things much better. So next question is about that. Now, a lot of you are already into psychiatry and you're practicing psychiatry, right? So, how frequently have you missed diagnosis of bipolar disorder? Is it one? How many of the times have you mistook it for depression? How many of the times have you mistook it for borderline personality disorder? How many times have you mistaken it for schizophrenia? Or how many times have you mistaken bipolar disorder for any of the other mental health problems? Now, is there somebody here who wants to choose choice 4 who says it's so classical, you cannot miss bipolar disorder? What do you think is the answer? Interestingly speaking, there are at least on Zoom platform itself, we have more than 50 plus participants, and not even one of them has chosen choice 4 as a choice. Uh, and in fact, if you see, almost all the choices are equally chosen, equally. Highest is 46%, which is the third choice. The least is 31%, which is the second choice. So basically, it's equally spread between 1, 2, 3, and nobody choosing choice 4. I guess that clearly says how bipolar disorder presents and how complicated it can actually be. Why I'm stressing this point is because that's exactly what makes bipolar disorder quite a challenge in clinical practice. One of the important points you need to understand is a lot of times patients come with depression episode. They come with a depression episode and they don't have a past for us to look at. They come for the first time with depression episode. You need to understand 1/3 of them might go on to actually end up developing bipolar disorder, which means you might need to change the diagnosis over a period of time. Getting it? So 1/3 of the people whom you have first time diagnosed depression might end up actually having bipolar disorder in due course of time. It can also happen as a clinician, we might have not elicited enough past history, which might make us misdiagnose it as depression, wherein the patient might actually would have had a past manic episode or a hypomanic episode. That also can happen, but it is important for us to understand, even in some patients who just have had depression episodes, after we see them, they might be developing bipolar disorder because it's not a rule that they should have had manic episode or a hypomanic episode before they come and meet you. Some of them might have it in future, is what you need to understand. So you need to suspect bipolar disorder, especially when the client who's sitting in front of you is much more younger, and if at all they have had even depression, if it's very discrete episodes, patients have very intense depression 2-3 months, then they get better, then again absolutely fine, then again they get into full clear-cut depression 2-3 months and then get better. If you actually see in real recurrent depressive disorder, the episodes are not that discrete. It's kind of much more prolonged and longer. There'll be 1.5 years, 2 years depressed many times, or at least a few months depressed. And the onset and going off is not kind of very clear cut. It is not very discrete in recurrent depressive disorder. Whereas in bipolar disorder, many a times there will be very clear cut, discrete episodes which we can see. And traditionally, we also see that their depression symptoms don't respond well when you start an antidepressant. You start an antidepressant, you expect patients to get better. These are the patients who might not get better that easily. That is when you should be suspecting of bipolar disorder as a presentation. So until you look forward for these things, you might not be able to catch these patients and be able to treat these patients. So that's very important point for us to understand. So if you're talking about bipolar disorder, there are two important types of bipolar disorder, right? Bipolar 1 and 2. Let me highlight an interesting point here. If you're talking about bipolar 2, if you take lifespans of these bipolar 2 patients, most probably 50% of their life will be euthymic or normal mood, 50% of their life will be almost depression. There'll be only a small percentage which makes them bipolar type 2. See, bipolar type 2 patients are almost like your recurrent depressive disorder patients. But if you see, there is a small slice of orange you see there, right? Where they can have 2% of cyclothymia and 2% of hypomanic episodes. Now, if you don't identify that orange slice, what happens is you might be loading them with antidepressants alone, not giving mood stabilizer. By doing that, what are you going to do? Most probably, you will reduce the quality of life of these patients by making them cycle more and more, or sometimes making them switch to manic episodes, or making them go through erratic subsyndromal symptoms. So, our job as a clinician, can we pick up that orange pie? Is the question. Can we pick up that small? See, majority of their life, they could have clear-cut depressive episodes, but they'll have these small slices of hypomanic cyclothymic episodes. Can you pick it up is the question. That's where a great clinician will do justice to the client by picking it up and helping these patients by reducing unnecessary exposure to antidepressants alone. If at all antidepressants are given, it is given under the cover of mood stabilizers, or you try to manage these patients only with mood stabilizers, because we know adding antidepressants alone can actually worsen the cycling and troublesome outcomes can happen. So that's an highlight which you need to know. That is exactly why you should pick up depression, first of all, correctly. And once you pick up depression, you also need to pick up what to say. Is it depression because of recurrent depressive disorder? Is it depression because of bipolar disorder? That's something you need to be picking up. So when you're talking about bipolar depression, why should you identify that? Most importantly, you need to look for a few important things. One is, if you pick up bipolar depression, the way you identify it becomes important. The symptomatology of bipolar depression becomes important. The treatment of it also becomes extremely important. So how do they present to you? That will help you to identify what is bipolar depression. I'll talk about it in a different slide. You also need to understand, once you diagnose bipolar depression, right, as a clinician, if I'm diagnosing a patient who's sitting in front of me, potentially having depression, which is part of their bipolar disorder, I'm always concerned about risk of switch. Whenever I'm giving an antidepressant, or even if I'm not giving an antidepressant, I'm worried to see whether they're going to switch to the manic side. So I'm constantly at lookout of it. You need to understand suicidal behavior is a complex phenomena and quite commonly seen in all mood disorders, especially bipolar disorders. So you need to be always at lookout for it and help these patients in these crises. Comorbidities are very high: substance use, anxiety problems, OCD, any kind of mental health problems, especially substance use, is going to be very high in these patients. So you need to identify and treat this as a part of their recovery process. It's just not prescription of mood stabilizer. Doing these things will help us. Now, when I'm treating bipolar depression patients, I also need to not just look always. I cannot just put them on antidepressant just like that, where I treat any other recurrent depressive disorder. The last session we spoke about antidepressants, right? So we have so many antidepressants, good ones. So it's just not like I start one and leave it. When I'm suspecting bipolar depression, you need to be looking at, first of all, you need to understand bipolar depression patients will not be responsive to your routine antidepressants that commonly. Second is you should always look for a switch which can happen because of antidepressants. And most importantly, you need to understand, if you very what to say, enthusiastically treat these patients with antidepressants alone, sometimes you might actually, instead of stabilizing the patient, you might destabilize the patient. That might only make their outcomes further worsened. So be careful about prescription of antidepressant. Ask yourself, are you missing anything? Is the patient who's sitting in front of you possibly having bipolar depression rather than depression, which is related to recurrent depressive disorder? So if you can look at it and be kind of cautious about prescribing antidepressant, you help these patients from getting destabilized. That's an important thing you need to look at. You also, when you're trying to maintain, right, you want to maintain these patients on mood stabilizers for a very long time, because we know bipolar disorder patients can have recurrent attacks of these episodes and mood problems. So you want to maintain them on long-term basis on mood stabilizers and help these patients. So these are some important things which makes bipolar depression to be addressed very, very importantly. Now, some of you might not be convinced. Let me give you my personal experience. I still remember when I started my practice, or even as a psychiatrist, budding psychiatrist, when I was in residency, right? I used to see a lot of my patients on valproate or lithium along with an antidepressant. And according to me, my feeling was, okay, these are unnecessarily being prescribed by the psychiatrist, and these are unnecessary polypharmacy is what I used to think. And most of the times what I used to do is to, okay, whenever I used to see patients on a small dose of valproate, like 250 mg, 500 mg, I used to immediately say, see, you're taking 250, 500 mg, which is a sub-threshold dosage. I think you don't require it. I used to stop it off. But over a period of time, my learning and my experience has told me that a lot of these patients actually might have bipolar disorder. I have ended up seeing them going on to have full-blown manic episodes. I've ended up seeing them switching when they are only on antidepressant. Those learnings is what has helped me to understand maybe bipolar disorder is an entity to look at. Bipolar disorder is not like what textbooks describe, okay, mania, depression, mixed state. It could be multiple things which can happen. There could be different levels of presentations. So you need to look forward to kind of pick up these cues in your patients. One of the important things which you should always look for and treat in patients with bipolar disorder is suicidal behavior. Why should you be looking specifically for suicidal behavior? You need to understand it is 8 times more common than general population. When you're talking about bipolar disorder patients succumbing to suicide, it is 8 times more common than general population. We all know depressive disorder is one of the most important reasons for patients succumbing to suicide, right? You also need to understand, if somebody has a diagnosis of bipolar disorder, they are twice more commoner compared to depressive disorder patients to succumb to suicide. So basically, mood disorder patients are the majority of the people who succumb to suicide in terms of the whole of mental health. In that, you need to understand bipolar disorder patients play a huge role. So you need to understand, almost like 1/3 of bipolar disorder patients at least attempt once in their diagnosis and lifespan. So bipolar disorder patients, at least 1/3 of them attempt once to succumb to suicide. And you need to understand, unfortunately, we lose about 10 to 20% of them with succumbing to suicide. So 10 to 20% of our patients with bipolar disorder, we would lose them because of suicide. So suicide is something we should always look for and identify in these patients and address it, because this is going to come in crisis times, right? And when do you see most of the time suicidal behavior? You see suicidal behavior when patient is depressed. So when you're talking about bipolar disorder, patients having depressive symptoms, you need to look for suicidal behavior. You need to understand 3 important components here. You can see depression symptoms as a subsyndromal feature. The patient might not have full-fledged depression, but might be getting into small, brief episodes of depressive feelings, which can last few hours to sometimes few days. That could be enough for them to succumb to suicide. So if you don't pick it up, you miss these patients. Next thing is, of course, picking up depression episode itself as a part of the treatment. Now this, as a clinician, we might pick up, because when they have full-blown episode, they're all good at picking it up, so we do help them. But subsyndromal, we don't pick it up, so it's good to ask them to maintain a mood chart and see whether their suicidal behaviors is linked with some of the mood changes, and try to work with them depending on whether the triggers or whether it is a substance use which is triggering the suicidal behaviors, and helping them to address. Very important thing you need to understand is mixed state. There is a lot of studies now pointing out that bipolar disorder patients, especially in mixed state, are even more prone than any other states, even more prone than even depression state. So our logic would say a patient who's in depression might be succumbing to suicide a lot. But you need to understand, a patient in mixed state is quite vulnerable to suicidal behavior. So diagnosing mixed states and treating mixed states becomes important. And I'm sure as a psychiatrist, treating mixed states is quite a challenge, because the efficacy of drugs kind of are much lesser compared to treating full-blown manic episodes and full-blown depression, right? So mixed states is a quite challenge for us to treat. We don't know whether to give antidepressants. We don't know whether to give mood stabilizers, how much of mood stabilizers, how much of antipsychotics. Should we at all use antidepressants? These are all challenges which comes in challenge of dealing with these patients with suicidal behavior, is what you need to know. Now, with this understanding, let me also highlight to an important point here. Okay, so in your clinical practice, you might end up seeing a patient who comes at a particular time of life, right? The person comes to you and you make a diagnosis of depression or mania or bipolar disorder, depending on various history. One of the things as a good clinician for us to diagnose and treat is to know, are we dealing with bipolar disorder or a unipolar disorder? So some of the important points you need to look forward is this. Does the patient have a family history of bipolar disorder at all? If they have, suspect bipolar disorder even in the individual who has come in front of you. If they have a family history, suspect. Second is, earlier the onset of a mood disorder, suspect bipolar disorder. If the patient has come to you having visited multiple other psychiatrists and have had clear-cut episodes, they say in 2009 I had 3 months of this episode, in 2013 I had this episode. If there are very clear-cut episodes, multiple episodes, suspect bipolarity. Understood? Not just this, you can also suspect bipolarity when patients come in with multiple psychotic symptoms, when patients come with agitation, when patients have significant decreased psychomotor activity, when patients have substance use disorder problems. When patients have substance use disorder problems comorbid with mood disorder, suspect bipolarity. Atypical features, hypersomnia, hyperphagia, making people who are eating more and becoming very obese, binge eating, people who are sleeping more, hypersomnia, atypical features, interpersonal sensitivity, all of them, preserved reactivity, they all make you suspect bipolarity rather than unipolarity. Diurnal variation, very clear-cut diurnal variation could also make you suspect bipolarity. Now, please understand, just because I'm telling this doesn't mean whenever you see a patient with these features, you diagnose them with bipolar disorder. You cannot. You need to look at multiple other features for you to ultimately say whether it is bipolar or not. But keep yourself on toes, because you need to be looking for these problems so that when you start a medication, if you see some changes happening, you can at least abruptly realize, okay, this is going somewhere in the wrong direction, and make tweaks in your treatment strategies. So that is something we'll be going in a few minutes time, where we'll be talking about various molecules and how we use various molecules. That's a wrong slide which came up. I'll go to the different slide. So before we go to the various drugs and talk about various drugs, let me highlight to you an interesting point here. So if you're talking about bipolar disorder diagnosis, right? It's kind of, let's imagine you have diagnosed it at a particular section. There could be a lot of factors which could have happened before. There are a lot of factors which could be happening after, which can influence the course of the illness. So, um, factors which would have happened before which could influence is, first of all, each patient whom we see have a particular genetic vulnerability, right? They have a particular vulnerability to a condition. They have family history. So it's also important for you to always ask for family history of bipolar disorder. Also importantly, ask for what medications they have taken and what has worked for them and what has not worked for the other family members. We have seen day in and day out in our practice that drugs which have worked in the family members is something which potentially can work in them also. So that could become one of the choices which could be. And this is something we have seen, especially with lithium usage. So we have seen responses going very well in family history. So not just for diagnosis, also ask for treatments, what medications they have taken and what has worked for them. That might give you an idea. More importantly, the past experiences and those can play a role. So a lot of times people have had child abuse, physical abuse, sexual abuse, all those kind of significant traumatic events, or people are going through multiple traumatic experiences as they're going by because of interpersonal issues, family issues, financial issues. They're all going to have a little more challenging course of bipolar disorder, which can make our treatments a little more complicated, right? From the time of diagnosis and future, if you see, each individual can have different course of bipolar disorder. Two bipolar disorder patients will not go through the same course of illness, right? They can have different courses of presentation. Substance use, which is quite a challenge, can change the course of presentation. We know alcohol especially can increase the cycling and lead to rapid cycling disorder. So that can make the uh, diagnosis and treatment of these patients little more complex. Most important, another point you need to know is patients with bipolar disorder, unfortunately, are also going to be more vulnerable, not just for various mental health problems, they're also going to be more vulnerable for medical conditions, diabetes, dyslipidemia, hypertension, lifestyle conditions. All of those are going to be much more bigger and challenges. And that also will make you choose the mood stabilizers, antipsychotics, and the drugs which we use, because we have to be fine tuning our treatment strategies based on the various changes which are happening in their course of their problem, depending on whether they are effective, not effective, what kind of side effects they are having, and what kind of comorbidities are happening. All those things will help us to diagnose and treat. So, before we go further and talk about various drugs, let me ask you a question. Which of the following drugs are having most neuroprotective effect? Do you think lithium has neuroprotective effect? Do you think valproate has neuroprotective effect? Do you think carbamazepine has neuroprotective effect? Do you think lamotrigine has neuroprotective effect? Which of the drugs has neuroprotective effect according to you? Out of these four choices, one, two, three, four, please put up your answers. Okay, so I see almost 50% of them telling, 55% of them telling lithium is the one which they think has neuroprotective effect. About 15% of them also have chosen valproate. A few of them have chosen carbamazepine. About 21% of them have chosen lamotrigine as having neuroprotective effect. Now, why should we even talk about neuroprotective effect in bipolar disorder? I'll come to that point later, but since we are talking about the drugs here, let me highlight a few important points for us to know. Before I explain about some of these drugs which I have given, if I had given one more choice, antipsychotics, do you think antipsychotics have neuroprotective effect? What do you think is the answer? Do you think neuroprotective effect could be seen in antipsychotics? Actually speaking, if you see, when you're talking about neuroprotective effect, lithium, lot of studies have shown to have neuroprotective effect. Interestingly speaking, now a lot of newer studies show that lithium might also have little bit of protection against even dementia. See, technically speaking, when we use lithium, right, we are always worried about neurotoxicity, right? Neurotoxicity. We know post ECT delirium can happen when patients are taking lithium. We know lithium can cause seizures, myoclonic jerks, neurotoxicity, altered sensorium, especially in higher dosages, and toxicity. But you need to understand there are also parallelly a lot of studies talking about lithium being neuroprotective to the extent even dementias. Are seen to be lesser, especially Alzheimer's dementia. The tauopathy, the amyloidosis processes are much lesser in people who are taking lithium. Now, please understand these are all studies which are pointing out, but again, it doesn't mean we can give people to lithium to protect them from dementia. It is not at that level as of now, but we need to understand neuroprotective effect is very prominent with lithium, and a lot of studies do point out to it. Carbamazepine, in fact, is one of the drugs which doesn't show much of neuroprotective effect. Valproate has shown to some extent. Lamotrigine, by the way, is another drug which has pretty much high amounts of uh, uh, neuroprotective effect, which has been kind of shown. Now, antipsychotics also, some of them, especially the antipsychotics which are used specifically in bipolar disorder, like your aripiprazole, quetiapine, risperidone, olanzapine, they all have some amount of neuroprotective effect, plus and minus, being shown in different studies. So lithium, lamotrigine have much more neuroprotective effect. Antipsychotics also do show some amount of neuroprotective effect, the least with carbamazepine, and valproate is kind of a questionable amount of neuroprotective effect being shown. Now, some studies with lamotrigine have shown in, in the prefrontal cortex, right? The N-acetyl aspartate is specifically known to increase when lamotrigine is being used, which leads to the neuroprotective effect. When you're using the antipsychotics, basically it shows it increases the same N-acetyl aspartate in the prefrontal cortex area, thereby kind of influencing it. These studies, especially in olanzapine, it is shown specifically in the prefrontal cortex area increasing. And you also see risperidone changing the glutamate-glutamine pool. Now, by changing the glutamate-glutamine pool, they are known to be having some amount of neuroprotective effect in olanzapine, risperidone. Even aripiprazole and quetiapine have shown some kind of a plus-minus effect in terms of neuroprotection. Getting it? So what you need to understand is when you're talking about bipolar disorder, it is no more, we are just talking about serotonin, norepinephrine. The last session, we were talking about depression and we were talking about serotonin pathway, we were talking about dopamine pathway, we are talking about norepinephrine pathway and those. We need to understand bipolar disorder is no more considered just as neurotransmitter problems. It has its own other effects. It's like your brain on fire. So brain on fire can have three important changes. You can have inflammatory changes which can happen. You can have oxidative stress which can happen. You can also have neuronal dysfunction which can happen as part of the brain being on fire. So a bipolar disorder patient's brain can be considered something like it's going through significant changes, and inflammatory process on one side, oxidative stress on the other side, and neuronal dysfunction on the other side. When you're talking about neuronal dysfunction, we always know about trophic factors being less and neuronal death being one of the important. So bipolar disorder is also linked with, if you see some of the patients with bipolar disorder, as years go by, the response to treatment deteriorates and they start dementing in their cognitive abilities and processes and those. So you will see maybe the ventricle sizes kind of increasing, the cortical atrophy increasing, basically because the trophic factors are much lesser, which leads to neuronal dysfunction and death. When you're talking about inflammatory processes, what has studies shown is as the bipolar disorder progresses, there is a constant increase in the tumor necrosis factor alpha. The tumor necrosis factor alpha constantly keeps increasing as the patient progressively deteriorates in their bipolar course. So that is possibly telling the inflammatory process is happening significantly. When you're talking about interleukin 10, this interleukin 10 is an inflammatory substance. And this inflammatory substance, right, is it is an anti-inflammatory substance. So when inflammation is happening, to prevent inflammation, some chemicals are released. This interleukin 10 is there. So interleukin 10 is seen in the initial bipolar disorder phases, but this interleukin 10 goes off in the later phases. So that fight of anti-inflammation goes off and the inflammation process worsens, and that is how the course happens. Now, why I'm stressing this point is because we do see clinically a lot of our patients responding well with medication for a few years, then slowly they start deteriorating. The same medications which worked very well might not work with them, and we need to augment it with a lot of different strategies. And sometimes we end up seeing side effects with these medications, and the effect comes down, which makes us change these medications. So you need to understand the person's brain could be significantly changing, and that could decide the course of action and what is to be done further and further. So one of the important factors is brain-derived neurotrophic factor, which plays a role in bipolar disorder. Now, brain-derived neurotrophic factor, I'm sure you would realize that it is discussed even with lithium. It is also discussed with ECTs, right? Where they say when ECTs are given and when ECTs are effective, the BDNF increases. Now, that brain-derived neurotrophic factor increases neuroplasticity and neural division and neural cell life, everything improves. Whereas here in bipolar disorder, as I mentioned to you, it's a progressive condition. So it can actually lead to neuronal dysfunction because of the lack of BDNF factor. Now, please understand, this doesn't mean all of our bipolar patients are going to worsen over years. In some patients where inflammatory process or an oxidative stress process or a neuronal dysfunction process could explain, they might have a deteriorating course. In many others, we might see that they actually, if they take their medications regularly and if they're compliant, they actually can function like anybody else, having almost normal lives like anybody else. So not necessary all of them are going to deteriorate, but in some of them where they deteriorate, this could explain the course, is what we need to understand. Now, when you're talking about what to say, when you're talking about bipolar disorder, it's a very complex condition, right? So let me kind of, first of all, give you a small point here, which will make it easy for us to remember and then take it further. When you're talking about bipolar disorder, we have a rainbow of choices. We have multiple drugs from which we can handle patients with bipolar disorder. Now, when you're talking about that, we use antidepressants in bipolar disorder. We use antipsychotics in bipolar disorder. We also use mood stabilizers in bipolar disorder. These are all different strategies we use. So, as already discussed, we could have mania or depression, where in mania we have much bigger list and many more drugs as choices available. Lithium, carbamazepine, and valproate are mood stabilizers. You have a bunch of antipsychotics which are very useful. Aripiprazole, azinapen, cariprazine is not. These are not available in India, but still very effective as per US studies and all. Olanzapine, risperidone, quetiapine, ziprasidone. These are all important drugs which are useful in managing manic condition. When you're talking about depression, the list becomes very less. See, I was in the initial talk talking about how important is it for us to diagnose depression and help these patients with depression. But unfortunately, our list to help these patients is much, much smaller. So if you look at only FDA approved drugs, there are just about three, right? Quetiapine, lurazidone, and olanzapine and fluoxetine combination is another drug which is kind of useful in patients with depression. Now, this is as per FDA. But you need to understand, when you're talking about maintenance, we have various drugs which can be used in maintenance: lithium, lamotrigine, aripiprazole, olanzapine, quetiapine, risperidone, and ziprasidone. These are all important drugs which are available for maintenance. So the list which is least available is for depression, but that is the most important problem for us to deal in our clinical practice. So that will tell you how it is difficult and a challenge for a clinician to help a patient with bipolar disorder. Understood? So that's something we need to know. An important point I would like to highlight here is this, that lithium, lamotrigine, antidepressants are some of the important drugs which are not FDA approved for bipolar depression, but you will see many clinicians will vouch for it and say these are great drugs in handling patients with bipolar depression: lithium, lamotrigine, and antidepressants. Now, antidepressants definitely have a role to play. It has to be used in many scenarios, but you need to understand you have to be very cautious about using it. You have to be very careful about using it, and you should be always looking for challenges which can happen because of antidepressants. You can destabilize the patient, you can increase the cycling of the patient, you can cause switch of the patient. All of those things are some things which you need to be really looking forward to kind of identify and address. So lithium, lamotrigine, antidepressants have a definitive role to play, but you need to understand, even though they are not FDA approved, they still have some sensible role to play here and there. So with this kind of understanding, let me ask you this question. Which of the following antidepressants have lesser chance of antidepressant induced switch? Which of the following antidepressants have lesser chances of an antidepressant induced switch? What do you think is the answer? Is it venlafaxine? Is it amitriptyline? Is it escitalopram? Is it bupropion? Which of the four has lesser chances of antidepressant induced switch? Okay, I can see that majority of them have chosen bupropion. That is 64% of them say bupropion has least chances of causing antidepressant switch, whereas the next one they have put is escitalopram. We do use escitalopram quite widely today. We know it can cause switch, but much lesser compared to definitely tricyclics and dual-acting antidepressants like venlafaxine and all. So venlafaxine, dual-acting antidepressants have much higher chances. Tricyclics have much higher chances. SSRIs do also have their own chances of increasing switches. Bupropion is supposed to be one of the least least chances of causing antidepressant-induced switch. So that's something which you need to have an idea about. Now, why should you know about this? Because I still remember in a lot of my patients, when I start antidepressants, right, the patients would come back and tell me, "Doc, I'm doing fine. Thank you very much." Nowadays, when patients improve very drastically, right, they kind of come with significant depressive symptoms, huge amount of depressive symptoms. You start them on medication, they drastically get better, and they come and tell you that you're the best, and they make you feel really good when they come for the follow-up session. You need to be little careful when patients do respond very well also. Now, earlier I did tell poor response to antidepressants is an indicator for bipolar disorder. Now I'm also telling you, be careful when a patient gets drastically getting better. So please remember, a lot of patients can switch, and they can switch very rapidly. And if you don't identify it, right, we end up into trouble. To give you an importance of how antidepressant switch is important for us to identify, I still remember just in the initial days of lockdown, this is the last patient whom I saw just before the lockdown happened and my clinical practice had to be, in-person clinical practice had to be shut down. This patient of mine whom I saw the last, I started him, he had 2 episodes of depression in the past, not treated, but he had clear cut about 3-6 months of duration. And this time he's been having depressive symptoms. So he came to meet me. I started him on escitalopram. Sorry, I started him on sertraline. He was just taking 50 mg of sertraline. Lockdown started. 3 weeks later, he was supposed to follow up. He said he's kind of doing better. Suicidal thoughts and those which used to occasionally come, all of those have come down. Another 3 weeks later, that is 6 weeks into the lockdown, and 6 weeks into the antidepressant medication, he said, "Doc, I'm doing absolutely fine. Thank you very much." And those. I said, "Okay, cool. Please continue the medication." And I said, "Follow up after 6 weeks." Now, when he followed up after 6 weeks, he said, "I've been doing many things. I've started a YouTube channel. I teach guitar to kids. I do this, I do that." Then he started saying, "I am doing some investment. I bought some, I've taken some loans. I'm doing this, I'm doing that. I'm spending money on various aspects. So suddenly it looked like he has done some artificial intelligence course. So what happened was I could see that he is just not better. It looked little unusual. I asked him questions, but I was not convinced of hypomania. Also, after talking to him, I thought, okay, maybe it is just a personality trait and he's just normal. I said, okay, please continue the medication. I kept the phone. After I kept the phone, a few minutes later, he sent me a message. Sir, this is my YouTube channel. I thought I will share it with you. That day night, he sent me another message telling I've started another YouTube channel which is talking about motivation. Now suddenly it looked like too many activities happening, and that is when I also heard that he sent some messages to the front office, sharing some greetings and some positive quotes and those, which was very unusual. That is when we had to call him back and say, boss, I think it's good idea for us to stop the antidepressant. Something is not fine. So we did stop, but unfortunately, in that few weeks where he had been on antidepressant and the financial decisions he had taken, he had got into about 4 to 5 lakhs of debt because he ended up taking multiple decisions, high risk decisions, and hurting himself. Now, of course, we stabilized him, we got him better. He's currently on lithium, doing well for himself. But as a clinician, it is our job to identify a switch happening, because if we don't look for it, we might not identify till clear cut manic symptoms happen. And manic symptoms could be too long drawn process. By then, huge damages can happen. So it's important for us to look for these things. And over talkativeness, extreme socialization, all of those things could sometimes help us as good clinicians to pick up. So if you don't look for it, you might miss these diagnoses, is what you need to understand. So let me highlight a few important points about these various drugs which we use and which are kind of important for us to know here. One of the most important drugs, which is gold standard mood stabilizer, is obviously lithium, right? Now, lithium uh, starts from the alphabet L. Easy to remember. Lithium seems to have tremendous amount of effect. In fact, nobody knows exactly how lithium works, even after being so effective for so many years. So there are many mechanisms of action. It seems to modulate GABA. It seems to modulate glutamate, thereby bringing in a balance and helping in patients in depression as well as in mania. It plays a role on 5-HT1A serotonin receptors and also plays a role in 5-HT1B serotonin receptors. So it plays on two Gs, GABA and glutamate modulation. It plays a role on 5-HT1A receptors and 5-HT1B receptors, thereby bringing about mood stabilization. Now, lithium is also important for you to remember is another L. It inhibits and decreases inositol production. It also kind of ensures that inhibits the GSK3, glycogen synthase kinase 3 enzyme. That is how it plays a role in mood stabilization. We now know lithium's action is significantly affected by its modulation of BDNF. It can bring about changes in BDNF. If BDNF is too much, it brings it down. If it is too less, it brings it up. So by modulating BDNF, lithium is known to have its neuromodulation effect, neuroprotective effect, and those. Do you know that lithium can change the size of the brain? There are a lot of studies today talking about patients who are on lithium on long term and who are especially responding to those medications obviously have a much bigger brain size. Now, specifically areas of hippocampus and amygdala having much more gray tissue matter, especially when they have responded to lithium. So all these things say maybe they have a good amount of neuroprotective effect, neuroplasticity effect, and that is something which we need to know. Now, lithium definitely we need to understand about its role in toxicity and pregnancy. These are things which we'll talk in a separate session where we'll be talking about special populations and challenges. There we'll be talking about lithium interaction and other problems. Another mood stabilizer which we need to know, which we commonly use in today's scenario, is valproate, right? Now, how does valproate basically work? We do a lot of times use valproate. Many times we in fact don't know the mechanism of action. The possible mechanisms of action can be easily remembered by that V itself. So one is voltage sensitive sodium channel inhibition. Voltage sensitive sodium channel inhibition. Now, I hope you remember what is this voltage sensitive sodium channel. In the first lecture of the series, we discussed about voltage sensitive sodium channel. What happens is when the electric current comes to the edge of the synapse, the voltage sensitive sodium channel converts this electric current into a neurotransmitter propulsion, right? So that voltage sensitive sodium channel, when it gets stimulated because of the voltage fluctuation, it opens up, it increases the calcium influx. By calcium influx, the neurotransmitters are released. Now that voltage sensitive sodium channel is inhibited by this valproate. Understood? It also plays a role in GABA modulation again, thereby kind of uh, having an effect. Now, basically, it increases the effect of GABA, thereby inhibits the various specific areas of the brain. Now, what is known about this voltage sensitive sodium channel and GABA inhibition is specifically they use something, a concept called as use dependent theory or open channels. The channels which are open or use dependent means the channels which are active, that is where it is inhibiting. That is why this work on epilepsy also, if these channels are open and active and it is being used by the condition, that is those channels are going to be inhibited and worked upon by the voltage sensitive sodium channel, as well as GABA modulation, which is brought about by the valproate also takes care of the transduction systems, right? It plays a role in multiple levels by working on the transduction system, thereby also having some amount of the neuroprotective effect which it can cause. Oh, valproate does play a role in calcium channel and glutamate sensitivity. It tries to inhibit these systems, thereby kind of reduce glutamate induced excitotoxicity, which can lead to further problems in terms of neuronal death and cell toxicity, right? So it inhibits the glutamate toxicity, which can happen because of the condition. Now, valproate is one of the common drugs which we use in our routine practice. Well, one interesting clinical point I would like to highlight here when you're talking about valproate is the point for us to remember that we commonly use divalproate. We also use sodium valproate, different chemicals, right? Please remember, uh, when you use a divalproate, which is plain, and when you use a divalproate, which is extended release, when you shift from that, you need to understand an extended release should be given in a little more higher dosage compared to the plain valproate. At least some studies say 8 to 20%. So 20%, about 10 to 20% higher dosage invariably is required for an extended release compared to plain divalproate. So that's an important point for us to remember. A lot of studies have shown the valproate and the divalproate is almost similar. Some studies show there is variations, but most of the studies say it's almost the same dosages which are required. But when you're going to an extended release format, you have to hike up the dosage at least about 15 to 20% so that it kind of gives enough cover. This is important because some patients will come and tell you that they are feeling sedated with a BD dosage and you want to give an extended dosage only in the night time. If you're doing that, maybe give a little higher dosage of it so that the patients might not have breakthrough symptoms. That's some clinical vignette which is good to carry. Now, when you're talking about lithium and valproate, right, it's a tug of war and very commonly used two medications. Where would you prefer lithium and where would you prefer valproate? Typically, lithium is preferred in patients who have typical manic symptoms and euphoric symptoms and classical bipolar symptoms, and patients who also have depressive symptoms, you can use lithium. Whereas, where do you prefer valproate? Valproate is preferred to be used in atypical patients. You should always use it when patients present with dysphoric mood states, patients who have irritable mood states, valproate is preferred. Patients who have mixed states, valproate could be preferred. Rapid cycling, valproate could be preferred. Cyclothymia patients, valproate could be preferred. A lot of studies say patients who have head injury and mood disorder, kind of organic mood disorder symptoms, and irritability and aggression post head injury, valproate could be preferred. So kind of clinically, if classical symptoms are there, classical drug like lithium is preferred. Valproate is more preferred in the atypical kind of presentation. So that kind of helps us to understand and deal with. One of the biggest challenge with valproate is the fact of using valproate in women, right? In fact, in British psychopharmacology guidelines, you typically, they say, don't give valproate in reproductive age group. Now, it's almost like requested to not to give at all. And now, if you remove valproate from your treatment armamentarium, it becomes very difficult, right? I mean, that's a very important drug which we use routinely. Now, valproate is to be avoided in people who are in the reproductive age group, female gender patients. Now, that's important for us to know. At least as much as possible, you need to avoid, or if you have to give it, you need to educate the patient about possible teratogenicity, and they should avoid pregnancy on this medication and those. Please remember, unfortunately or fortunately, data says 50% of the pregnancies are unplanned pregnancies. So basically, it means that most of your patients who might become pregnant might be unplanned. So you should be kind of reiterating them when they're on valproate that they should avoid pregnancies or take enough precautions or change the molecule, take enough supplementation. They need to work on those. We'll talk about pregnancy and psychotropics in different section, but I thought I'll highlight to you here because that's one of the common mood stabilizers we use, and that's going to be a challenge in our day-to-day practice, how we address these patients and those. So one of the important drugs we use in mood stabilization is carbamazepine and lamotrigine. Now, carbamazepine and lamotrigine basically seem to work on the alpha subunit of the voltage sensitive sodium channel. They work on the alpha sensitive subunit, alpha subunit of the voltage sensitive sodium channel. So carbamazepine and lamotrigine both work on this area. Now, let me ask you this interesting question here. If you're going to deal with only FDA approved strategies, tell me which of the following drugs is not FDA approved for bipolar and depression? Which of the following drugs is not FDA approved for bipolar depression? Is it quetiapine, lorazepam, olanzapine, fluoxetine combination, or lamotrigine? Which of the following is not FDA approved? Is the question. Please, Shriram, put up the choices. Not FDA approved. Now, about 50% of them have chosen lamotrigine. A lot of them have chosen olanzapine and fluoxetine combination, lorazepam, as well as quetiapine also. In fact, quetiapine, lorazepam, olanzapine, fluoxetine, lamotrigine, they all work very well in bipolar depression patients. But if you're talking about FDA approval, and if you want to practice based on only on FDA approval or something like that, then you need to understand lamotrigine, which is such a useful drug in recurrent depressive disorder as well as bipolar depression. You might not be able to use it because it is not FDA approved for bipolar depression. The other drugs, the three, quetiapine, lorazepam, and olanzapine fluoxetine combination are supposed to be the FDA approved strategies for bipolar depression, not lamotrigine. Okay, that's something which we need to know. Next interesting point is this question. So I'll also take it up with a question again. Which of the following drugs prescribed could be most important cause for lethal rashes? Is it lithium, valproate, carbamazepine, lamotrigine? Lithium, valproate, carbamazepine, lamotrigine. What do you think is the answer? Lethal rashes, what should we be worried about? Lithium, valproate, carbamazepine, lamotrigine. Now, why I ask this question is because when we prescribe mood stabilizers, right, we are always worried about switch and effectiveness and those things. One thing which we should always remember is carbamazepine. and lamotrigine, especially lamotrigine is a drug where you should be extremely worried about lethal rashes which can happen. By the way, you can also have benign rashes which can happen, but you should be specifically looking for lethal rashes and kind of address that of lamotrigine. Even carbamazepine can cause rashes which can be Steven Johnson syndrome, but lamotrigine is even more important drug, to the extent that when you prescribe, it is a good idea, especially with carbamazepine and lamotrigine, when you have started the medication on our prescription, document and tell the patient any rashes to immediately meet the doctor or reach an emergency system to be evaluated and those things, because we don't want patients to be continuing the medication and develop full-blown Steven Johnson syndrome and be treated. Now, it's an interesting point here for you to remember. I spoke to you about valproate just some time back, right? I'm talking about carbamazepine and lamotrigine on the same slide. So, interesting point of interaction you need to know is valproate can increase the level of lamotrigine. Carbamazepine can decrease the level of lamotrigine. So, if a patient is on valproate and if you want to introduce lamotrigine, introduce at 50% lesser dosage than the usual way of introducing. Whereas if the patient is on carbamazepine, it is a good idea to go at a much higher dosage. But please understand, whenever you introduce lamotrigine, it is always good to start slow and low. Start slow and low. Sometimes you can go to give even pediatric dosage, even though a lot of guidelines say start at 12.5 mg and go up. If there are some companies which have 5 mg pediatric dosage lamotrigine, it's a good idea to even start at much more smaller dosage. Let me highlight you an interesting point here. One of my patients had allergy to penicillin and a few other NSAIDs in the background in the past. On that, she had recurrent depressive disorder, which was not responding to very high doses of any of the antidepressants and combination of antidepressants, augmentation with antipsychotics. So I thought, okay, it's high time that we introduce lamotrigine. Now, with all this past history of allergic reactions and those, I did explain the patient that, okay, see, we can consider lamotrigine, but you should be reporting if you have rashes, and explained everything. We started this patient on lamotrigine. When the patient had reached about 50 mg of lamotrigine, the patient messaged me telling, Doc, I have a few spots which is reddish in color. What do I do? It was just a few spots and it was on the upper limb. No insect bite, nothing else, and an exposed area. So now we had dilemma because we were not sure whether this rash is part of a Steven Johnson syndrome. If we stop, my worry is one side is, will it become Steven Johnson syndrome? Another side is, if I remove lamotrigine, what other drug would I give? Because I was hoping this patient is going to respond to lamotrigine and help this patient. Now with this dilemma, what happened was, I explained all the pros and cons. I said we'll have to wait and see. There was no mucosal involvement, very small spots, not painful. It was not raising. It was not painful. Very clear cut small spots, not kind of spreading across. So all those things made me. I also spoke to one of the dermatologists, asking them, could this be an indicator of Steven Johnson syndrome? They said doesn't look like, but very difficult to say because it can pop up overnight. So we said let's wait and see for 48 hours to 72 hours. We continued the medication, monitored the patient. The patient's rashes luckily vanished, and this patient is about 2-3 years now, completely euthymic and doing well at lamotrigine of 200 mg going on. So what I'm highlighting to you is, these are great drugs which will work in patients, but we need to work with the clients and help these clients, because when they go through challenges, they look up to us, and it is our clinical acumen and help counseling them and talking to them and telling, yes, we also don't understand, let's wait and see, let's work together. When we do that, kind of we can gain supportive collusions and actually make things work for the client ultimately. So the best part of the story is patient responded with lamotrigine, and luckily, touch wood, the patient is doing fine as of now. So I want to highlight that every rash need not mean Stevens-Johnson syndrome. It's a good idea to always take second opinion, third opinion. It's always good to err on the side of caution, but sometimes you might be removing a molecule which might be effective in the patient. So look at the pros and cons, take calls based on that, monitor the patients closely. If they have rash, it doesn't mean it's going to be Stevens-Johnson syndrome, but most of the times it's always good to err on the side of caution. With that understanding, since we are talking to a lot of budding psychiatrists, one of the important points I would like to highlight is this is not a molecule which I use very commonly because of its own tolerability and effectiveness, but it's quite commonly prescribed by many other psychiatrists I know. So, and which is the drug I'm talking about? I'm talking about oxcarbazepine. And the moment oxcarbazepine is discussed, right, we know a lot of post-graduates don't even read about oxcarbazepine and they think it is something related to carbamazepine. And they think it is related to carbamazepine, it is a metabolite of carbamazepine. But let me tell you, oxcarbazepine is not a metabolite of carbamazepine. Oxcarbazepine is structurally similar to carbamazepine. It is not a metabolite of carbamazepine. So please remember, they can ask you in your viva, don't get stumped. Oxcarbazepine is structurally similar to carbamazepine, but it has nothing to do with carbamazepine. It is not a metabolite of it. Next important point you need to understand is when you're talking about oxcarbazepine, it is not an active drug. It is a prodrug which gets ultimately converted into Lee-carbazepine. And this Lee-carbazepine is important because a newer molecule, which is just S enantiomer of Lee-carbazepine, it is S-Lee-carbazepine, is being kind of developed, researched, and worked upon. Maybe it's going to be there at some point of time, at least as an anti-seizure drug. Will it work as a mood stabilizer? Only time will answer. Because most of these drugs will come as an anti-epileptic drug, then get into psychiatry for its mood stabilization effect. That's how it works. One of the main reasons of using oxcarbazepine because of its safety profile. Now, we all know we can use atypical antipsychotics commonly in patients with mood stabilization effect. So atypical antipsychotics basically produce this by three methods. One is, there is, of course, a typical antipsychotic or any antipsychotic is going to be a D2 blockade, which will help. Why does this play a role in mood stabilization? Mainly because of its antagonist effect in the 5-HT2A receptors, and very importantly, 5-HT1A partial agonism. This 5-HT1A partial agonism gives an advantage of using atypical antipsychotics in our challenging problem, which is the challenging problem in bipolar disorder patients, depression, right? So in patients with depression, when you want to treat, you want to kind of use this advantage of 5-HT1A partial agonism. One of the very important drugs which is useful in bipolar depression, which is a atypical antipsychotic, is lurazidone, right? Lurazidone. Now, lurazidone, again, L for you to remember. So it's a good idea for you to know. Lurazidone is basically having two important actions. It is an antagonist at the D2 receptor. It is an antagonist at the 5-HT2A receptor. It is a 5-HT2A antagonist and a D2 receptor antagonist. You also, since I'm talking about L, you also need to understand lurazidone is very effective. In fact, it is an FDA approved strategy for bipolar depression, maybe because of its 5-HT1A partial agonist effect. It has a 5-HT1A partial agonist effect. It also has a 5-HT7 antagonist effect. Now 5-HT7 antagonist effect, if you remember last time session, we did speak about a multimodal serotonergic drug. Which drug did we speak about last session? Vortioxetine, right? So that also has a little bit of 5-HT7 receptor activity. So lurazidone also seems to have some amount of 5-HT7 antagonist activity. So basically, it plays a role in cognitive functioning and cognitive processing to some extent, and maybe help these patients in better cognitive processing of information. Now, this 5-HT1A partial agonist, some of the other important 5-HT1A partial agonists we have are aripiprazole, buspirone, brexpiprazole, lurazidone, vilazidone, ziprasidone, and of course, quetiapine is also a 5-HT1A partial agonist. So why am I stressing this point? Is because these all drugs could be potentially having some amount of anti-manic effect, can also be used in patients with depressive symptoms. So in patients with mixed affect and those, some of these have to be considered at some point of time or the other. So this is how you choose these drugs based on which receptor activity they might be able to show. One of the other important drugs which we use almost like a mood stabilizer, even though it's an antipsychotic, is quetiapine. Quetiapine basically works on D2 antagonism. It works on 5-HT2A antagonism. It also is a partial agonist of 5-HT1A. That is exactly why it is used in depression symptoms. Just now I told you, right? Now, quetiapine also is known to have effect on H1 receptors and alpha 1 receptors. It blocks the H1 receptors and alpha 1 receptors. Why is this important? Quetiapine blocking these H1 receptors specifically clinically leads to its important side effect, that is sedation, and alpha 1 blockade leads to orthostatic hypotension. So that's an important drug. Now, why I'm specifically pointing out about orthostatic hypotension and alpha 1 blockade with quetiapine is today we have a lot of geriatric population having late onset psychosis or dementia related aggressive behaviors, or even bipolar disorder presenting at geriatric population, right? So what happens in these patients is we end up giving quetiapine because we know quetiapine has a good safety profile and can be used. But be careful when we start quetiapine, especially in a little higher dosage. If it started, alpha 1 blockade could be very, very high, which can lead to orthostatic hypotension. In young people, orthostatic hypotension could be just some giddiness, but in elderly people, it could lead to a fall. And geriatric population, a fall could turn out to be a costly affair. They can unfortunately have a fracture or become bedridden, and that leads to a lot of physical health complications. So kind of whenever we read these molecules, it's good to know at least some crucial receptors and how they act. Thereby, when we kind of apply these things repeatedly, we learn how to kind of understand these actions and help these patients in a much better way. Now, I try to, whenever we discuss various molecules, try to highlight some specific side effects and some specific receptors, because clinically, we might not be able to remember everything which is given in textbooks, but our aim is to kind of find out what drug would we choose, how we handle these patients, and address these drugs with rainbow of choices we have. I will go back to the same slide where we kind of started and discussed. When we choose patients with bipolar disorder, we and treat them, we have different drugs which are effective in different phases. Choosing which drug works at different points of time is going to be always a clinical skill. We always get better at it over a period of time with a lot of learning, with a lot of experience, and kind of learning to deal with various scenarios. We are coming to the end of this session where I kind of highlighted to you how different drugs are utilized and what is kind of important. I'll try to take up a few questions in the next few minutes so that any one of you have any questions, if you post in the discussion, we'll kind of look at it and keep it very practical. Okay. As of now, I don't see any specific questions. So I guess I think I have highlighted to you a fact which is very important with relation to mood stabilization. I thought somebody might ask this question. I thought I'll wait for it at that time. Somebody has raised hand. I see. Hari, if you can type the question, it would be better so that we can take it further. One of the important points I also would like to highlight here is this. So I'll ask you this question so that let me see how you answer for us to kind of discuss it. Abrupt stoppage of which of the following drugs can have adverse effect? Abrupt stoppage of which of the following drugs can have adverse effect? Fluoxetine, lithium, venlafaxine, paroxetine. What do you think is the answer? Please put up, Shriram, 4 choices: fluoxetine, lithium, venlafaxine, paroxetine. Which one of these things can cause problems, abrupt stoppage? There's a reason I've asked this question, because, and I've kept it to the end, because that's something which is very, very crucial for us to know. About 43% of people, or 43% of people have chosen paroxetine as one of the drugs. Maybe they're right. If you have listened to the last lecture, you would choose paroxetine and venlafaxine as drugs which you should not abruptly stop, for a simple reason, is because paroxetine and venlafaxine are short-acting drugs. So when you stop, they can cause a lot of withdrawal symptoms. That is also true. But one of the important drugs here you should remember is lithium. Lithium abrupt stoppage is known to worsen the course. It's known to lead to relapse of bipolar symptoms, rapid cycling, and those problems. So abrupt stoppage of any mood stabilizer is to be avoided. Abrupt stoppage of lithium is very much to be avoided in patients. In fact, it is very good to taper, and if at all you want to taper and stop, you should go very slow with tapering and stopping lithium, because otherwise you can lead to adverse reactions of relapse of symptoms and those things. Fluoxetine is one of the drugs which is pretty long acting, and you can you very, very rarely will end up seeing withdrawal symptoms. So stopping that overnight might not cause that much of withdrawal symptoms compared to venlafaxine and paroxetine. So venlafaxine, paroxetine, you should not abruptly stop because of its withdrawal symptoms. Whereas lithium, you should not abruptly stop because it can change the course of the whole illness itself. So be careful about stopping any mood stabilizer abruptly. And a lot of your mood stabilizers are what? Anti-epileptic drugs, right? And if you stop any anti-epileptic drug abruptly, you are in trouble, because it can lead to seizure attacks. So let me highlight to you something clinically which I have found over a period of time. I'm sure you'll also relate to it in your clinical practice. If you see patients with bipolar disorder being diagnosed and treated, right, as days go by and when they're following up with you regularly, you see, as they follow up and if they're doing fine, first follow up, they say, I'm doing fine, sir. Thank you. I'll continue the medicine. Second follow up, they say, yes, I'll continue. After third, fourth follow up, slowly they'll start asking you a question. Can I stop the medicine? Can I stop the medicine? Can I reduce the medicine? So I have seen one thing: the drive to stop medicine starts increasing with every follow up which happens. So the drive to stop medicine increases. Why I'm highlighting this point is because if you don't bring it up in your clinical discussion with the patient, what the patient is going to do is he's going to abruptly stop the medicine, which will make his problem worsen significantly and come back to you. We don't want that to happen, right? It's a good idea for us to talk to them. Are they thinking about it? What makes them think about stopping medicine? What makes them think that they will never get the episode again? What are the lifestyle changes they have brought in? Are they taking some psychotherapy help? Are they implementing some of the learnings? You need to look at lifestyle changes. You need to see whether they're even ready for stoppage of medication. Is it worthwhile to consider of stopping medication? And those, talk to them about it. As doctors, we don't want to bring it up, because if we bring up these questions, we have to counsel them. So we have to spend a lot of time. We don't want to bring them up. But what do they end up doing is abruptly stop the medication. By abrupt stoppage, they worsen their course of illness. So before they abruptly stop, you bring up these discussions which can help you to help these clients in a much better way as best as you can. Now, somebody has asked this question. Dr. G.V. Raman Rao has asked this question: how to tackle polypharmacy in bipolar disorder type 2 with medical comorbidities. Now, obviously, we need to understand. See, polypharmacy looks like a bad word, right? A prescription with multiple drugs looks like a bad word. That is how I also used to always think. Okay, for drugs in the patient, oh, crazy psychiatrist is put unnecessary medication. This is what I would end up thinking. But you need to realize that not all patients are going to be on multiple drugs. And some patients, unfortunately, have to be on multiple drugs because their illness is quite complicated. Maybe they don't respond to the routine drugs. Maybe we are not giving adequate dosages of the routine drugs. a lot of times what happens is we introduce drugs, patients get better, so we keep the drug. We don't even ask ourselves, can we remove one of the drugs and those things? So it's important for us to realize as clinicians, as we are starting drugs, are we ready? What is the rationale of starting the drug? What is the rationale of stopping the drug? And one of the things I've started doing in my practice over a period of time is, especially whenever my patient is on more than two drugs, I start writing in the prescription telling the reason the patient is on three or more drugs. Like I say, patient has residual sleep issues, not responding to any other medication, so benzodiazepines have continued, or zolpidem has been continued, so that any other psychiatrist who sees that doesn't abruptly stop the medication and lead to further problems. If the patient is on small dose of lithium, and if it is causing some anti-suicidal effect, I want the patient to be continuing that and not stopping it abruptly. Another psychiatrist who might end up seeing in a cross-section level might stop it thinking, okay, he's only taking 300 mg of lithium, wherein he is already on valproate, very good dosage, he's already on lamotrigine, he's already on quetiapine, so might not be necessary. So we don't want them to abruptly stop lithium. Maybe lithium was having a little bit of anti-suicidal effect, so we don't want to stop. So it's a good idea, if I have enough rationale that this patient has to be on multiple drugs, it is good to put it on the prescription, tell the patient why this particular combination of drugs are being given. So when I put it on the prescription, I also understand we're talking the same language as clinicians. We join together in helping these patients get great quality of care. That's our job, to help these patients to have great quality of care. That's something to work upon. Can we give olanzapine for maintenance dose of bipolar disorder patients? Can we give olanzapine as maintenance dose of bipolar patients? I'll just put up the slide again for you. If you see that slide, you will get to know the answer for it. Mm, as per FDA, as such, if you see, olanzapine is one of the recommended strategies for maintenance therapy. But you also need to understand, olanzapine alone might be less effective in preventing depression, whereas olanzapine and fluoxetine combination might become very useful. But the bigger problem of olanzapine is huge amount of metabolic syndrome problems, right? And again, a lot of studies today speak about inflammatory pathway being a common pathway in bipolar disorder and obesity and those. So I don't know how many of our patients we can keep them on olanzapine. If they're really responding well and not much of side effects, why not? We can keep them on olanzapine. But be aware, they might have subsyndromal depressive symptoms and being prone for depressive symptoms. Now, somebody has asked a question on lithium having anti-suicidal. Is there an anti-suicidal dosage for lithium? See, typically speaking, we know there are two drugs in psychiatry which seems to be helping patients in reducing suicidal behavior: clozapine and lithium. Clozapine and lithium are two drugs which are known to have anti-suicidal effect. Now, when you're talking about lithium, especially, it is very funny to find that there are studies where lithium in water content is more, and suicide reported in those geographical areas are much lesser. So, is there an anti-suicidal dose or a dose which is required? Very difficult to say. We do see in our practice, even patients in smaller dosages, as small as 300 mg to even 600 mg, which might not be reaching the serum lithium levels at a therapeutic dosage. We have seen them reducing significantly their impulsive behaviors, reducing significantly their high risk behaviors, including self-harm behaviors and suicidal behaviors. So we do see patients even in smaller dosages responding for anti-suicidal behavior. But if you see that the suicidal behavior is part of their whole depression process, if they are kind of suicidal because of the depression, then most of the times you have to go to a much higher dosage of lithium. Please also understand, lithium as an augmentation strategy is also used in depression, right? And when you use lithium as an augmentation strategy of then you use very, very small dosages of lithium, 300 mg to 600 mg also is used as an augmenting. So there is no specific anti-suicidal dosage of lithium. Even starting small dose can start helping. It depends on what are you trying to treat. Are you trying to treat the patient's depression with lithium, or are you trying to treat the mood stabilization of the patient, or are you trying to introduce lithium as an anti-suicidal agent? So these are things which you need to ask yourself, and that will help you to decide the dosage depending on the patient's tolerability and those. I think we have answered most of these questions. It's 9/8 now. It's a beginning of the new year. So I guess we have had an opening day with the ongoing series of this essence of psychopharmacology. I've tried to keep it as simple and clinical as routine so that all of us learn together, ultimately help these people who come up with distress the best way possible. Thank you very much. Have a great time. We'll catch up the next Friday with the next in the series, and looking forward to meet all of you next Friday. Thank you very much. Have a great time. Thank you.
Thank you very much, sir. So we meet next Friday on antipsychotics as the session.
Yeah.
Thank
Thanks,
you.
Sriram. Thanks.
Thanks, everyone. Good night and meet